Shweta Singhai from Bengaluru.
Respected teachers and dear colleagues, a very good morning to all of you. I am Dr. Shweta Singhai, a rheumatologist from Bengaluru, Karnataka, and I am the session coordinator for the classic session on emerging virus and rheumatology, COVID and beyond. Well, the year 2020 brought the whole mankind on its knees and had in fact turned our world upside down. A new entity called the novel coronavirus had entered our lives. Come to 2022, I think we have just about started to understand the disease spectrum caused by this virus. In fact, many of us have used steroids and JAK inhibitors in our COVID patients. The first topic here is this session. I shall first invite the chairpersons. May I please invite Dr. Yojana Gokhale, Professor of Medicine and in charge Rheumatology Services, Lokmanya Tilak Medical College, Sion, Mumbai, and Dr. R. Ravichandran, Consultant Rheumatologist, SIMS, Chennai. He is the Professor and Head, Department of Rheumatology, Madras Medical College, Chennai. Welcome, sir. Welcome, ma'am. The first topic of the session is immunomodulation in COVID. The role of cytokine blockade by Dr. A.V. Ramanan. Well, he is the consultant pediatric rheumatologist, Bristol Royal Hospital for Children, Professor, Pediatric Rheumatology, University of Bristol. COVID-19 vaccination is efficacious in reducing the infectivity and decreasing morbidity and mortality. However, initially vaccine hesitancy was quite common, presumably due to worries related to side effects. It was also seen that a few people developed flares and some developed new autoimmune reactions. To throw some light on this topic is Dr. Padmanabhan Shenoy, who shall give us an update on COVID vaccines in rheumatic diseases. Dr. Shenoy, I welcome you on stage. He is the Medical Director, Center for Arthritis and Rheumatism, Cochin. Rheumatologists also need to be cognizant of the changing landscape of emerging viral pathogens, as they may present myriad clinical features. Given the current scenario of global epidemiological factors that influence viral emergence, we should expect a growing number of future emerging pathogens. COVID infection itself can be prolonged. Well, is it really long COVID or another entity in itself? Dr. Subramaniam R. from Mysuru shall be throwing light on the topic long COVID and or another virus, the story of newly emerging viruses and rheumatic health. Dr. Subramaniam is professor in the Department of Rheumatology and Immunology at JSS Medical College, Mysuru. And finally, we shall be having a question-answer session and an audience interaction moderated by Dr. Ravichandran and Dr. Ma'am from Mumbai. Thank you.
So, first speaker would be Dr. A.V. Ramanan.
Thank you very much. It's a significant topic, but I think Sunday morning is what we call as a graveyard slot. Very few people left, but I'll still try and make it as exciting as possible. And these are my disclosures. I was part of the Recovery Pediatric Steering Committee. I did run a trial of tocilizumab in India, which I'll touch on. Ran 2 trials of baricitinib globally. Was an advisor to Roche and Lilly. For long, we've talked about the possibility of viral infections, malignancies, and a host of inflammatory pathologies giving rise to an exaggerated release of cytokines, what we either termed as cytokine storm syndrome, cytokine release syndrome, or different forms of hemophagocytic syndrome. And they all came to bear in the paradigm which is now well established for 2 years now, that when we get exposed to this one type of coronavirus, the SARS-CoV-2 virus, what you have in some individuals is a predilection for a pneumonitis, which affects particularly the type 2 pneumocytes. We've also found that the individuals, particularly elderly individuals who are most likely to die, have defects in either innate or adaptive immunity. And one of them is to produce a good antiviral response, you need type 1 interferon. And we know that individuals who died had excessive amounts of anti-interferon antibodies. But what happens once the virus isolates itself into the alveoli? It activates the monocytes, macrophages, and then you have an exaggerated release of cytokines in a predisposed host. It was about this time Dennis McGonigal and I, who had been working on different forms of cytokine release syndromes in rheumatological conditions, talked about the immune cartography in the era of COVID-19, what we've historically recognized as macrophage activation syndrome in the context of Still's disease or systemic JIA or even Kawasaki. And we spoke about the tissue basis for cytokine storm phenotypes within COVID-19. We talked about the intestinal epithelium and the macrophage. We spoke about how you can have myeloid and lymphoid cells and how you can have a localized cytokine storm, which is what we see in the context of COVID, which is a lung-specific phenotype, which is why you don't see some of the markers of inflammation we've historically associated with cytokine release syndromes in the form of a very high ferritin. And here we talk about what happens in the first wave with the SARS-CoV-2 virus particle, the tissue-resident epithelial cells acting on the alveolar macrophages. And in the second wave, when the individual becomes much worse, you get a release of cytokines, which includes IL-1, IL-6, GM-CSF, and TNF. Now, if there was one thing that's changed the landscape of management of COVID, and that's dexamethasone. At the start of the study, as someone who was part of the steering committee, many infectious disease doctors and intensive care doctors were aghast that we would be trying steroids in an infectious condition. And what I'm demonstrating here, even though this is a busy slide, is if you look the mortality of patients in UK, this was about 8,000 patients, the mortality of patients who required oxygen or beyond was reduced when you had dexamethasone. But there's one salutary lesson here. If you didn't need oxygen and you got dexamethasone, you were at much higher risk of dying. So dexamethasone is a fantastic drug if on COVID-19 you were ill enough to get oxygen or need oxygen or supportive therapy. And this probably, as you know well in this context here, indiscriminate use of steroids in those who did not need oxygen did result in harm. So what I'm showing in this meta-analysis curve is if you were needing invasive mechanical ventilation with COVID, you did well with dexamethasone, mortality-wise. If you needed oxygen alone, you still did well with dexamethasone. If you didn't need oxygen, there was a tendency to harm if you were given dexamethasone. So dexamethasone is a fantastic drug only in the moderate to severely ill COVID patients. It is not required in the mildly ill patients, and it might actually cause harm. Sometime in March 2021, almost 18 months ago, the calculation was at least 1 million lives have been saved by this cheap and cheerful drug in the time from July 2020, when the DEX results came out, to March 2021. And you can certainly double the figure by the time we talk now in November 2022. So dexamethasone's value, which is well known to rheumatologists, was at last being realized by the infectious diseases doctors, but only to be used with caution and only to be used in those who need it. So let's look at the other drug in which I've spent some time doing trials, tocilizumab. Why tocilizumab, you might ask? Because we speculated early at the start of the COVID-19 pandemic that IL-6 could explain a lot of the pluripotent effects we were seeing in these patients, such as raised CRP. We can explain the thromboembolic risk that these patients had because of its activation of vascular endothelial cells and increased coagulability. So the reason there was increased thromboembolism in COVID patients was because of vascular endothelial activation, because of excessive IL-6. And the answer was not in aggressive anticoagulation, but the answer was in immunomodulation. And in fact, more patients succumbed from super aggressive or supra therapeutic anticoagulation than appropriate immunomodulation. So this cartoon is to demonstrate that IL-6 could potentially explain the multiple facets of the problems that were happening within the immune landscape in the cellular architecture of the patients with COVID-19. So there were 3 trials I'll touch on, including 2 I was involved in. The first one was looking at critically ill adults with COVID-19. So these were adults who were admitted to ICU. They had to be within 24 hours of being admitted to an ICU. And they looked at the role of tocilizumab versus sarilumab versus control. And the primary outcome was very simple. Did you live or die? And the number of days of organ-free support. So you had 400 patients to IL-6 blockade and 400 to control. And it was stark. If you had an IL-6 blocker, you had 10 days more organ support free, which meant not needing a ventilator, not needing dialysis. Hospital mortality was reduced in these critically ill patients who got tocilizumab, mostly on top of dexamethasone. So IL-6 blockade on average will save 1 life for every 10 patients it was treated with, which is pretty stark for the COVID-19 pandemic in the era before vaccines. But that was in the critically ill, so you may ask, what about in those who are mild to moderately ill, needing oxygen but not yet in intensive care? And this was a recovery trial where they took 2,000 patients in the tocilizumab arm, 2,000 in standard of care, and they found again mortality was reduced in the group which got steroids plus tocilizumab compared to steroids alone. And here again the calculation, if you treated every 25 patients with tocilizumab, you had 1 additional life saved. And this was on top of the efficacy that you gain with dexamethasone. 80% of the patients, 80% of these 4,000 patients had already received dexamethasone. And not only did it reduce mortality, it also reduced the need for oxygen and mechanical ventilation, which, if you recall at that time, there was a growing concern about the impact of multiple patients needing ventilation, and there was a decreased need for ventilation. What about the Indian context, you might ask, and I'm pleased that with Arvinder Soin and several colleagues, we ran a trial, a randomized controlled trial, 180 patient trial, looking at tocilizumab plus standard of care versus just standard of care. And again, about 80% of these patients got dexamethasone, and our results were very similar to that seen in Recovery, REMAP-CAP, and other trials. I then was part of the WHO meta-analysis group where we looked at all trials of IL-6 done across the world, which included 10,000 patients from 27 trials. And we clearly showed IL-6 blockade did reduce 28-day mortality. And this was on top of the effect of reduced mortality seen with dexamethasone. But the drug I'm most proud and closely associated with was baricitinib. Now, we've been using baricitinib for several years. We've always thought of baricitinib as an immunosuppressive drug with an increased risk of infections. We've always counseled our patients that you may have a risk of herpes and other viral infections. In February 2020, 2 months after the outbreak of the pandemic in China, Justin Stebbing, a colleague of mine in Imperial, published this paper in The Lancet saying artificial intelligence predicts baricitinib will not only be an effective therapy because of its anti-IL-6 effect, but it has an antiviral effect. Now, who would have thought a JAK kinase inhibitor that we were worried about herpes infections would have, acting through the NUM kinase pathway, an antiviral effect? So I worked with Lilly, and we did a 1,650 patient randomized control trial which recruited patients across Europe, North America, Latin America, few centers in India as well, and in Asia. And the first paper we published in 2021 September. Ours was a much more robust design. So we took patients with COVID-19 pneumonitis who at standard of care plus dexamethasone plus placebo versus baricitinib. All the other trials weren't placebo-controlled trials, they were open label. And the primary endpoint, of course, was day 28 mortality. And we showed that compared to placebo, baricitinib plus standard of care on top of dexamethasone significantly reduced mortality. And this was 80% of the patients were on steroids and 20% weren't because they were recruited before steroids became standard of care. But the effect of reduction of mortality was seen in both groups of patients. Now, in this study, we excluded anybody who was critically ill because we thought if you are intubated, ventilated, or on ECMO, an oral drug is not likely to be effective for you. This is demonstrating whether you had baseline steroids or not, and the reduction in mortality was seen in both groups, although 80% of these patients were on steroids. But FDA then said, no, we want you to do a study in critically ill patients, even if it's an oral drug that you give by nasogastric tube. So we went on to do a 100-patient randomized placebo-controlled trial exclusively in ventilated or ECMO patients with COVID-19. And we were shocked to see reduction of 28-day mortality even in ventilated patients with a 14-day course of baricitinib, which was 40% in the bari group compared to almost 60% in the placebo group, a significant absolute risk reduction of 18.8%. And this wasn't just day 28 mortality, it continued all the way to day 60 with a significant reduction in mortality in this group, which got baricitinib. So the key message is baricitinib-treated patients showed less ventilator-dependent days, spent less days in the hospital, and in terms of side effects, because there was a lot of concern about thromboembolic complications. In fact, the thromboembolic complications, as I've alluded to before, is more a feature of the inflammation rather than the drug, and there was no increased risk between the placebo and the treated groups. And then the recovery trial looked at 8,000 patients, 4,000 randomized to baricitinib, and 4,000 to standard of care. Almost all of them got steroids. But the interesting thing about the recovery trial was a fifth of the patients also got tocilizumab. In spite of getting steroids and tocilizumab, the critically ill patients, when they got baricitinib, still had a reduction in mortality, demonstrating the power of added immunomodulation in the seriously ill patients. So this is my last slide. This is the up-to-date WHO living guideline on COVID-19. And if you come down, there are only 3 drugs which WHO says work in COVID-19. Corticosteroids, which I've shown you the evidence for, at least a couple of million lives saved. IL-6 receptor, on which I've been participating in 2 trials, which is clearly a good drug, or baricitinib. Now, hopefully, COVID is behind us. But if there is a resurgence, my preference after dexamethasone would be baricitinib first before tocilizumab. Why? Because it's got a short half-life of 12 hours, and you can quickly stop it if you have a risk of secondary bacterial infection, whereas a single dose of 8 per kilo of tocilizumab is likely to stay in the system for 6 to 8 weeks. And of course, in the critically ill patient, it's perfectly reasonable to trial all 3, although serially. Thank you very much. Happy to take any questions at the end.
Thank you so much, Dr. Ramanan, for such a lucid presentation. Any questions?
So, Lars Torsko, coming from Sweden, Karolinska. So this was a very elegant overview. So my question is, many of these patients also suffer from long COVID. So did any of these treatments have an impact on long COVID?
That was in the remit of any of the studies. So the short answer is don't know.
Okay.
Ram, do you think we can translate this to other viral infections? Ventilated patients for influenza, for instance?
Yes, so we can't translate it in action yet. We can translate it in trials. So we are about to start a trial of IL-1 blockade in Vietnam in dengue patients. So we're taking patients above the age of 12 because dengue as an arbovirus has got some similarities of a proportion of dengue patients getting critically ill with hemorrhagic shock and vascular leakage. And what is it about that proportion of patients who sometimes succumb in spite of supportive care? So we're trialing anakinra in that population, Ho Chi Minh City. We hope to start probably at the start of next year in the Hospital for Tropical Diseases there. That is the goal, but it's going to be much harder to do these trials in the sort of context we've been able to do. COVID was a unique setting. But I think this is providing a paradigm shift that immunomodulation is the answer for infection-mediated inflammation rather than repeat trials of antivirals and antibiotics.
Thank you for an excellent presentation. I loved it. And we are rheumatologists, and one thing I want to remind that indiscriminate use of dexamethasone in the beginning of the pandemic has resulted in thousands of people with avascular necrosis of the hip that I've been seeing. And most of them unnecessarily had dexamethasone because of the panic of their families as soon as they were diagnosed as COVID. This is just a reminder for every one of us that panic can create itself a problem.
Yeah, and I think the sad reality there was nobody cottoned on to the fact that patients who did not need oxygen, who went on dexamethasone, actually did badly. It wasn't statistically significant, but it was clinically significant. And this is the perils of not reading the paper fully and going by headlines in lay press and taking dexamethasone indiscriminately. I couldn't agree more. There is no role for dexamethasone unless you're on oxygen or beyond.
Well, I was going to ask the same question. Why is it so?
Why?
Why there is no need of dexamethasone?
Well, the answer is simple. You know, while we have a heightened sense of fear about this virus, the fact of the matter is, if you expose 1 million individuals, it's only a proportion who get moderately ill and then a proportion who get severely ill. A lot of the others deal with this coronavirus as they have dealt with other coronaviruses like a bad flu. And I think using dexamethasone in those is probably suppressing the innate immune system drive, which isn't probably healthy. And in the context in which there is probably fungal infections, mold and damp, you're probably predisposing these individuals without knowing what their comorbidities are. So there's a time, place and role for immunomodulatory therapies. It isn't for everyone, it isn't for every time.
Did you notice any aggravation in the patients with arthritis, especially rheumatoid arthritis, who suffered from COVID? It's just a question.
No, you know, these trials were very focused on the acute scenario. The primary focus was, did you live or die at day 28? There was no follow-on. One of the unique things of the National Health Service, which is much maligned in UK, is I'm more proud of the therapies we showed didn't work, which I didn't have time to. We showed hydroxychloroquine doesn't work. We showed azithromycin doesn't work. Each of them in 8,000 patients. We showed colchicine doesn't work. We showed convalescent plasma doesn't work. We kept showing all of these spurious therapies which have been touted by the high and mighty to not work. But the 450,000 patients we recruited in that time was all about short-term outcomes and not about any of their comorbidities getting better or worse or long COVID. So apologies, I don't have an answer for that.
Can we follow up on the next speaker? Okay. Thank you, Dr. Ramanan.
Thank you.
If any more questions and if there is time left, we can always ask Dr. Ramanan.
Yeah. Can the slides please? Good morning. It's a really, after a lecture of Ramanan, Dr. Ramanan, who has done landmark trials and saved millions of lives all over the world. It's a really awesome moment. And thank you, Dr. Ramanan, for this wonderful experience. So I will be speaking on COVID vaccines in immunosuppressed patients in our story, lessons we have learned over our journey with COVID vaccines in India. When the COVID stuck and the vaccines were being given, there were a lot of questions, and we are all not having patients. We had a lot of time to think, so we asked to ask questions. Whether our patients will respond to this vaccine similarly, do all the vaccines will work, similar protection, what is the effect of immunosuppressants on immunogenicity, and later on, once the COVID pandemic was over, and still we asked the questions, are the boosters required in our patients? So this was one of the first papers, which first cohort. We started building our cohort of this 134 patients, 100 of them having an autoimmune rheumatic disease, and 34 of them who are having some other kind of rheumatic disease like fibromyalgia, osteoarthritis. We could very clearly see, you can see here down that those patients who are having rheumatic diseases had a lower titer of antibody, 238 versus 608. And another striking point was that you can see the antibody titers generated following Covaxin was very, very low when compared to Covishield, 238 versus 5.24. So we were slightly, this was a very initial data which we generated. Then we thought we should, first and clear message was very clear that patients with immunosuppressed patients generate less humoral response in our patients. Then second thing which was very clear, then we recruited some healthy controls from the healthy people 30 to 40 years of age, and we did the antibody titers in them. You can see very clearly here, the blue dots are that of Covishield and the red dot is that of Covaxin. You can very clearly see here the Covaxin, a lot of people were negative, and it was very clear from this paper, this set of observation that Covaxin, it's an inactivated vaccine, has less humoral immunogenicity. So then we started asking, we thought, let's validate, because it may be we were also shocked because this is a vaccine which was being told that we are going to give 50% Covaxin to our cohorts, to Indian population. So are all vaccines equally immunogenic? To just validate what our findings, we recruited around 550 patients of autoimmune rheumatic disease. You can very clearly see what happened. Covishield had a 94% seroconversion with a titer of 447, while Covaxin had 40% seroconversion, meaning majority of patients who were on inactivated vaccine did not mount any humoral immune response. And the viral neutralization was almost nil. This later we published in Annals of Rheumatic Diseases as a letter. And more importantly, it was a very satisfying moment. We were one of the first groups which communicated to the government of India at the highest level that this Covaxin, inactivated vaccine, doesn't work in population. And following that, there were a lot of deliberations, a lot of meetings with them, but we kept it very confidential, not to panic the people. And India has definitely taken, government of India has taken, because after due deliberation, that they restricted the use of Covaxin to less than 10%. And what is the outcome of that? We can see the yesterday's newspaper from China who has used inactivated vaccines. COVID-19 cases touch a record high. Beijing resorts to community lockdowns. While India, we can very clearly see the Diwali season, all of us sitting here without COVID, and much COVID is almost not there now. And probably we have played a significant role. And I would like to thank IRA for supporting all this research from our side. And so the question, a lot of people ask me, okay, this Covaxin has less antibody titers and autoimmune rheumatic disease, less antibodies. Antibodies is not everything. Immune system has cell-mediated immunity, a lot of other stuff. Is it clinically significant? Does it translate into clinical infection? So what happened, we took our cohort again, 630 patients, as I told you, who were well characterized. We followed them up for 150 days, around for 4 months. And what we could find was that 7.4%, 47 of them developed COVID. Then we stratified them based on who was poor responder, moderate responder, and good responder. And poor responder means they have not mounted antibody titers. Anti-S less than 212 we took as moderate responder, and good responder was more than 212. How this 212 came is basically the 212 is what is required for neutralizing the antivirion. So if you look here, and it was out of the 47 patients, out of the 107 patients who did not respond, 19 of them developed, that is 17% developed breakthrough infection. Vis-a-vis in good responders, it was 3.94%. You can see the survival curve. Red one is the good responder and the blue one is the non-responder. So there is a clear-cut differentiation which starts at 2 months between the two groups. So antibody titers predict the protection to a great extent. And the same thing was shown again with which vaccine gives better protection. It was again very evident. You can see the red one is the Covaxin, the blue lower one is the this one is the Covishield, and the upper one is the Covaxin. Covaxin is definitely breakthrough infection, much more when compared to Covishield. And this is our Annals of Rheumatic Disease paper which we had published. So we very clearly showed that patients who are autoimmune rheumatic disease patients has less humoral immune response, and inactivated vaccine does not work as good as the vector-based vaccine, and antibody titers are a correlate of protect. This was one of the first papers which proved that. Then we thought, how our patients who are not responding, what are the factors? The two major drugs which we found were rituximab and methotrexate were hampering the immune response. So we took our patients who are on rituximab, and we have a database where we look at the B cells and a regular interval in these patients. So we had 33 rituximab treated patients who were vaccinated in the initial days, out of which 22 of them had B cell repopulation, 11 of them did not have any B cell repopulation, or B cells were depleted in them. As you can see here, what this chart shows, because for lack of time I don't want to go into details of this, but very clearly you can see this blue chart, blue dots are the one who B cells are repopulated, and most of them seroconverted. And so before 6 months, most of them were B cells were not repopulated, and none of them they could mount an immune response, humoral immune response. The message is very, very simple. If the gap between the last rituximab infusion is more than 1 year, most of them seroconverted. And if it is less than 1 year, always look at the B cell count. And if the B cells are repopulated, vaccinate them, or otherwise wait. So that is the simple message for a practicing clinician, and this was published in IGR, which was given one of the best paper awards yesterday. So what about methotrexate? This is a parallel investigator blinded randomized control trial, MIVAC-1 and MIVAC-2, which was published in Lancet Rheumatology a couple of months back. In the MIVAC-1, what we did was we held methotrexate during the first and second dose of vaccine, and in the MIVAC-2, we held only during the second dose. Why did we do this? Because, as we know, if you hold methotrexate, they are at a higher risk of flare. So, to cut the story short, we have randomized around 300 patients odd, and if you look at antibody titers, this is MIVAC-1 and this is MIVAC-2. What it clearly showed is that holding methotrexate definitely improves immunogenicity. You can see this. Both methotrexate hold arms have a higher antibody levels when compared to methotrexate continue arm. But when you compare holding methotrexate twice or once, it did not have any superiority. Meaning, if you hold, see, you can see here, if methotrexate was held twice in MIVAC-1, it had an antibody titer of 2,500. In MIVAC-2, methotrexate was held only once, and it had again antibody titer of 2,500. So it was almost similar. But those patients who methotrexate was held twice, the flare rate was around 25%, vis-a-vis if you hold methotrexate only once, the flare rate is around 10%. So what does it say? Stopping methotrexate only after second dose led on to less number of flares and improves the immune response, and that's what we could learn from these two studies. And then almost similar time we have been working on, when people come and ask us whether vaccine will give a better protection or infection. Initially people thought infection will give a better, vaccine will give a better, 2 shots of vaccine is going to give a long lasting protection. So we recruited some 100 odd patients from our cohort. Some of them had only COVID infection, some of them were double vaccinated, and some of them got an infection, 1 dose of vaccine following an infection. And this is what is called hybrid immunity. You can see the amount of antibody produced. Antibody titers were 49,200 in the vaccine group, while 6,000 in the infection plus vaccine group, indicating that those who get an infection and a single dose of vaccine develop a very high amount of hybrid immunity. And we predicted that India will have a very, very mild Omicron wave based on our population data. And this is our breakthrough paper, effect of hybrid immunity on Omicron breakthrough, 1,000 odd patients, out of which 534 were vaccine alone group and 372 were hybrid group. See the difference. Breakthrough was 25% in the vaccine alone group, vis-a-vis 5% in the hybrid group, indicating that why India survived this very bad Omicron wave, when other countries have a bad Omicron wave, is possibly because of this hybrid immunity which we had developed during the Delta wave, and we had paid very heavy price for that too. Now this is the latest research what we are doing now, which is getting published, which has not been published yet. So what happened? So when we thought hybrid immunity generates a huge amount of antibody levels to these patients, what happens? Somebody is infected, got a 1 dose of vaccine, he is getting a 2nd dose of vaccine. Is it going to boost the immunity? The common sense says it will boost the immunity. So we thought we will recruit some patients and see what happens. This was very surprising finding. What happens predominantly is those who are having hybrid immunity, if you give a 2nd dose, the antibody titer falls. Not only antibody titer falls, the Omicron neutralization dips to a great extent. You can see this viral neutralization. It dips to a great extent. So it indicates that in those with hybrid immunity, giving a frequent dose of vaccine may not be a great idea. This is under review, may get published in next month or so. But on one side, we have a problem of plenty. People with hybrid immunity, lot of antibody, lot of immunity. We give them vaccine, their immunity comes down. On the other side, we have a lot of people on rituximab or heavy amount of immunosuppressants who do not develop an antibodies, or those who have developed inactivated vaccines. The two questions were, so the answer was very clear, we need to boost those who have not developed antibody response. The two questions which we tried to answer was, which vaccine should we give as a booster? And second question was homologous or heterologous. And third question was, when should we give the booster? So we did this randomized control trial, which was presented yesterday in our meeting. So it was a very small, because we recruited patients who did not respond to the vaccine. So to get a patients who have not responded to vaccine is not that easy. So we get around 48 patients in Covishield and 43 in Covaxin. Then that is the time that unfortunately Omicron wave was going through, and a lot of people developed Omicron infection post second dose or third dose of vaccine, and we ultimately could analyze 38 patients in Covishield arm and 29 in Covaxin arm. The results were again, the first set of experiments showed us that boosting happens in most of them. Antibody levels, neutralization, T cell response, all of them increase. But again, the results were very interesting, that inactivated vaccines did decreased humoral response. Those patients, for example, who has got Covishield, if they get a Covishield, they get a better immune response vis-a-vis Covaxin. And the group which was worst was those who got all doses of 3 inactivated vaccine. First 2, 3 is Covaxin, their immune response was not great. So it is always, somebody has received an inactivated vaccine, it's always a better idea to give a vector-based vaccine, because so that they mount some kind of immune response. So the last question was when to boost. This is the ongoing study. We had taken 300 patients. Some of them were hybrid cohort. Hybrid means, I told you earlier, last immune infection, the control group, we know they were infection naive. 70 of them were infection naive, and the 231 were hybrid. And we gave them vaccines at different period time point, more than 9 months, 6 to 9 months, and 3 to 6 months. And we looked at the anti-RBD titers. The results were interesting. If we give longer the gap between the last immune hit, be it infection or vaccine, they respond better. For example, if somebody gets a vaccine after 3 months, as I told you earlier, if somebody has a hybrid immunity and you give second shot within 3 months, their immunity comes down. If it is 3 to 6 months, it goes up to some extent. But more than 6 to 9 months, the immune response is extremely good. So if somebody asks you when to boost, the ideal period, if it is a hybrid cohort, is more than 9 months. And as you can see here very clearly, 3 to 6 months, 6 to 9 months, and more than 9 months, the immune response goes on increasing as the gap increases. And because of lack of time, I am not showing the other results. To the take-home message, which is probably coming out of this study, those who are infection naive, which is very rare to find in our population, infection naive, maybe 10% of population is infection naive, you can boost them at any time because they have very low antibody titers, boosting works. But if it's a previous infection is there, somebody is COVID infected earlier, you have to wait more than 9 months before you boost. That's the ideal period. So this is the crux which is coming out, and we are working on it. So we have tried to answer all these questions. On one side, we have a hybrid cohort who have a lot of antibody response. We have to wait for some, it gives a lot of protection, and we have to wait for 7 to 9 months before you boost them. On the other side, we have infection naive patients. We have to give, we can vaccinate them at any time because their antibody response is less. And when should we give? When should we vaccinate? Answer is very clear. Which vaccine should we give? It is always better that Covishield or a vector-based vaccine performs better than the other vaccine. And thanks to, these are all, it's a big team which has worked on this. Thanks to all my collaborators, all my, Sakir and Pankti, especially from other institute, all others are from our center. And thanks IRA for supporting many of these studies. We have been supported by Indian Rheumatology Association. And thank you everyone for patient listening.
Thank you, Dr. Shana, for such a wonderful work. Any questions?
Wonderful work, Dr. Shanai, and I think so. Government of India has changed their protocol and restricted the Covaxin to less than 10%. It's a big support to Indian population, and I recommend, not recommend. I'm very less. I just, it's my thought. Dr. Shinoy should be recommended for Padma Shri from the IRA part, and he should try.
No,
yes, yes, it's a population support study. And my question is, should we stop methotrexate for the same other vaccines, influenza or pneumococcal or some?
Yes, it's already shown in earlier studies from Korea, etc., that if you give influenza vaccine 2 weeks after the vaccine, better if you stop their immune response is much better.
Okay. Padmanabha, first of all, congratulations for the excellent work done, and you deserve much more recognition than probably people are aware of. I just want to ask you, you must have identified the protective titer of these two vaccines that we have used in India. And did Covaxin achieve protective titers at all? But we know that the government of India did not withdraw this vaccine for valid reasons. I mean, if they did that, there would be a lot of panic. But what exactly was the step taken by the government?
Sir, basically,
once you informed
I will tell you, when we had this data in April, which was 2 months into the vaccination program, I am being very candid. I have never spoken like this, or because this is a close family I am talking, and the era is of that panic is over. We had sleepless nights. I think I have spoken to Sapan boss. Very few. One option was to go all out and tell the world that this doesn't work. But that will create a lot of giving anti-vaxxers a arm to fight against vaccines. So I thought we should not do that. And I met a lot of ministers and communicated at the highest level possible and kept it very, very confidential. And I thought we will delay the publication of this till the government takes some stand. And they did wisely, and they reduced the production of Covaxin and did not open up new factories of Covaxin. They were planning to open up more factories. That was withheld. And ultimately, I think they could not ban it because of political reasons rather than scientific reasons. Because that time it was indigenous Atmanirbhar Bharat and Covaxin story was going on, and it may be politically damaging for a government to withdraw it completely. So we never held it a press conference. We never revealed it to the public that this is. And in scientific journals we had published, and all the people who are aware of the vaccine committee is aware of this. But I think this tells us a big story. It tells us a story why research by people who do not have any conflict of interest needs to be there, be it with any drug. Otherwise, this kind of stories will never come out. I'm sure I spoke to a lot of people in government institutes. They were all scared. They knew this was happening, but they were scared to come out with this data.
Because my hospital was one of the centers for providing the vaccine, and I know for sure people were getting as much of Covishield as much of Covaxin. So those, yeah.
No, those people who really got Covaxin, I'm not sure. They must have got something else also. They are, you know what we see is not what we may not be the truth.
But you see, unsuspecting public. I mean, we
very true, sir. But ultimately, I don't know.
Sorry for the intervention, for the want of time. When my speaker is waiting, we will have a discussion at the end if time permits. Please.
I'm here.
Please.
And I want to make a thing. I'm an example. Standing in front of you, I took Covaxin, 2 boosters and the vaccine, and I got such a terrible COVID. And on top of that, I did not need oxygen, but I was given steroids like anything. So I'm a case here, I just survived by the skin of my teeth.
Great, man.
Now I invite Dr. Subramaniam from Mysore to talk about long COVID or another virus, story of newly emerging viruses and rheumatic health. Over to Dr. Subramaniam.
Good morning. At the outset, I would like to thank the organizers and for putting me in such a difficult position after Joss Butler and Virat Kohli has batted. It's like Dinesh Karthik trying to swing somewhere. Hopefully, I'll hit somewhere. My only disclosure is I may not be having any original work on long COVID at all. So the layout of the talk is basically, it's a case scenario, and then we discuss about long COVID and post-acute infection syndrome, emerging viruses, and then I conclude. The case scenario goes like this. It's a 28-year-old woman who was diagnosed to be having COVID-19. She was self-quarantined at home and received supportive care. And post-acute phase, she had symptoms suggestive of fatigue, lethargy, intermittent dizziness, and tachycardia. There was positional retrosternal chest discomfort with multifaceted cognitive symptoms, in the form of poor concentration, poor memory, non-specific head buzzing, worsening anxiety, and brain fog. Musculoskeletal symptoms included restless legs, non-specific paresthesias across their hands, feet, and generalized body ache. Definitely, when we see a patient like this, we do investigate to a great extent, and we find that we usually don't have any answers per se. So NICE has actually defined post-COVID syndrome or post-COVID-19 syndrome as signs and symptoms that develop during or after COVID-19 infection, continuing for more than 12 weeks, and are not explained by any alternative diagnosis. These symptoms, as noted in the case, can affect any system in the body and they will fluctuate over a period of time. And it is used to describe both patients with asymptomatic COVID-19 from 4 to 12 weeks or post-COVID-19, that is after 12 weeks of infection. So long COVID, basically we are talking about long COVID in the context of SARS-CoV-2 infection, but we have experienced the similar symptoms with other coronaviruses like MERS and SARS. Development of constipation symptoms will persist, which is a sequelae of an acute disease. And this can be with a plethora of symptoms, basically unremitting fatigue, post-exertional malaise, and a variety of cognitive and autonomic dysfunctions. So this syndrome or long COVID syndrome is not new. I mean, we have been experiencing a lot of post-acute infection syndrome following viral diseases, which have been described for different viruses per se. And in the acute phase, as pointed out by the first speaker, there is a lot of extensive immunological and multi-organ dysfunction. But once there is a complete recovery, there can be a significantly increased risk of an assortment of adverse clinical effects, even with those with mild disease. The only thing is probably these symptoms have got better over time with the virus mutating, and probably those with Omicron may not be having too much of these symptoms per se, but in the acute phase or in the initial stages of the pandemic, those who have had different variants of the disease, probably they do tend to suffer more than what has happened after Omicron. So long COVID syndrome, post-COVID syndrome, it can be in 4 forms, but there can be post-intensive care syndrome, post-viral fatigue syndrome, long COVID, or symptoms pertaining to a persistent or permanent organ damage. This was a study published by NHS where they had studied the hospitalized patients of COVID, and they found that in the not in the Omicron stage, the previous the Delta stage, where those who were admitted, 45% of them, they required ongoing medical care after the acute phase, 4% required inpatient rehabilitation, and 1% of the patients had permanently required an acute care. This was probably because of an extensive lung damage in most of these patients that they had studied. So long COVID permanent damage is basically lung scarring, childhood inflammation in the form of MISC, and of course thrombotic effects in the form of stroke, embolism, blood clotting, and heart damage. And we have a plethora of neurocognitive and mental impacts. Thankfully or not, I'm not too sure, neurocognitive or mental impacts seems to be constituting the maximum percentage of long COVID syndrome as compared to the others, unless they have had a pre-existing lung damage or something else. So if you look at this particular cartoon, as we go down the body structure, the symptoms of long COVID tend to come down, and most of it is related to the neurocognitive or some form of a chronic pain or chronic inflammatory status that we usually come across in most of the rheumatic diseases. So the estimates of prevalence of long COVID vary substantially, which is heavily dependent on clinical, social, economic impacts given the global breadth of SARS-CoV-2 infection. There is persistent viral or viral remnants that are there in the body, which leads to a sequelae of long COVID. There is a component of autoimmunity, but need not necessarily be autoimmunity in most patients. Dysbiosis, that is the gut flora that is there, that has always been this thing to study, but that has played a significant role in the persistence of inflammation in long COVID. And there is latent virus activation followed by an antibody diversity in most patients. The tissue damage that is caused by long COVID is basically because of persistent or a low-grade lingering inflammation. Then you've got a whole lot of immunological and hormonal profiling that has been done in most patients with long COVID syndrome. And what we see here, the immune cells do get altered, the cytokine profile changes. More importantly than not, what we see in chronic pain or chronic fatigue syndrome, or what of the neurocognitive effects that we see in chronic pain syndrome, they have been caused by the levels of plasma cortisol, which were decreased compared to the healthy or convalescent controls in most studies. So it need not necessarily be a decreased cortisol levels. It can be decrease in the fluctuations of the cortisol levels in these patients, which will give rise to a lot of chronic pain kind of a syndrome. And this was supposed to be the most significant hormone, which was this was most significant factor in the propensity score for long COVIDs. So what they did in New York, in Mount Sinai Hospital, what they did was they took all the healthcare workers, the convalescent control, and those with long COVID syndrome, and what they found was all the scores, or all the parameters compared to health status, dyspnea, fatigue, all those things were more common in patients who had got long COVID syndrome. So this was the propensity score that they had graded, and they found that all these scores were significantly higher in patients than those with long COVID symptoms. So they had suggested that there is an involvement of a persistent antigen, and there can be cross-reactivity between coronavirus and other viruses like herpes virus, or more commonly what we see in our routine is the Epstein-Barr virus. So the chronic inflammation was less consistent with the presence of autoantibodies. So autoantibodies need not necessarily be demonstrated in most of the patients with long COVID syndrome. Of course, I will come to rheumatic health later on. So the management so far don't have a definitive management for long COVID syndrome per se. It has more often been symptomatic and supportive, primarily because they do tend to cross across or shift across departments from one department to the other because they don't get a definitive answer to most of these symptoms. What about emerging viruses? Emerging viruses are newly identified pathogens which are mostly zoonotic or vector-borne infectious agents and have consistently or relentlessly threatened public health and are caused by deadly outbreaks of global concern. They have a selective advantage of infection in new hosts, and there are many factors that contribute to the emergence of new zoonotic diseases. There is evolutionary progression of virological determinants, change in human demographics and behavior, dramatic increases in the movement of people and animals, and environmental factors such as ecologic and climatic factors. So these are some of the viruses that we have encountered in the turn of the century, starting from dengue, going on to Lassa fever, Zika, yellow fever, COVID-19, Ebola, swine flu, and all those things. Whether there is a change in the management of these symptoms in the post-acute phase, we are really not sure, but many people do tend to experience a lot of symptoms post-acute stage in any of these infections, specifically if they have had a good amount of organ damage in the acute phase per se, or if there was a good amount of an immunological phenomena that was going there in the acute phase. Then in the COVID era, we basically have severe acute respiratory syndrome by SARS-CoV-2 and influenza virus, and there is an entity called severe fever with thrombocytopenia virus, that is SFT-SV. And there is a lot of innate immune sensing and viral evasion strategies as far as coronaviruses are concerned. There is a difference between whatever symptoms we experienced in patients who have RNA viruses as compared to those with DNA viruses. The emerging viral infections have expanded their range of hosts. They have spread beyond the presumed geographical territories, and they have altered their pathogenic characteristics and are caused by agents not previously deemed as pathogenic. So there are a lot of contributing factors to these emerging and re-emerging viruses. So there are human factors, there are environmental factors, there is impact of mass gatherings and emerging viral infections. There are viral factors such as genetic recombination and the ability to infect multiple species in these viruses. And there are a lot of immunological factors which was already shown by the first speaker. There are immune responses which are varied amongst different viral infections. That's what we usually see in dengue, COVID infections and all those things. And there is a whole set of immune profiling that is going on in this body system per se post a viral infection. What happens to rheumatic health on patients with long COVID or any emerging viruses? So viruses associated with rheumatic syndromes can be both challenging diagnostically and therapeutically. Diagnostically, certain virus-associated syndromes, rheumatic syndromes, can mimic rheumatic diseases such as rheumatoid arthritis, systemic lupus erythematosus, and Sjogren's syndrome. Therapeutically, administering immunosuppressive therapy to certain chronic viral infections such as HBV or HIV infections can be detrimental to the host, which I will show it in my subsequent slides. So when you see a virus like HIV, there is a difference in the presentations in the pre-ART era and the post-ART era. Probably HIV, we are more scared of these viruses because of a persistent viremia that is there in the body, which is well controlled with the antiretroviral therapy, which luckily is not so with other viral diseases like SARS-CoV-2 or dengue virus. So in HIV in the pre-ART era, we had a plethora of rheumatological symptoms, including diffuse infiltrative lymphocytic syndrome, vasculitis and all those things, which are not seen in the post-ART era. And post-ART era, we definitely see more symptoms pertaining to the drug treatment per se. Parvovirus B19, we don't have a definitive antiviral agents to this particular virus. So we do see a lot of autoimmune phenomena or an immunological phenomena in these patients. And of course, in hepatitis B and C viruses, one is a DNA and the other one is an RNA viruses. We are very well acquainted with the HPV-associated PAN, reactivation of these viruses following a biological use, persistent arthropathy in the form of rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, and fibromyalgia. In HCV-associated arthritis, HCV-associated cryoglobulic vasculitis, and arthritis following antiviral therapy is not so uncommon that we have usually seen in patients with hepatitis B and hepatitis C infections. Then most notably of interest for rheumatological I think this is the most common thing that we have seen in India, post-chikungunya virus. Post-chikungunya virus, again, in the late phase, we have got a lot of arthritis and tenosynovitis. How this chikungunya virus is basically develop into a persistent arthritic symptoms or persistent, most of these patients, they tend to diffuse out from the primary caregiver per se. So there are various consultations. So we are not exactly able to follow up these patients with chikungunya virus. We don't know whether this virus has triggered a phenomena called seronegative arthropathy or a seronegative rheumatoid arthritis per se, which we do tend to label them over a period of time as the disease or as the disease persists. So in conclusion, we have to know that post-acute infection syndrome commonly exists among all viruses. It's not necessarily so in SARS-CoV-2 also. There is not a specific, it is not specific to a single viral etiology. There is always a dysbiosis and there is a gut, lung and a neural axis that is there in these patients. Rheumatic manifestations are not unique and sometimes can be treatment related, and there is no single therapeutic options. With this, I thank you.
So thank you very much for an excellent lecture on the virus and rheumatic diseases. Any questions? Can permit only one or two questions.
I just have a comment, and if you, there was this in the section of basic implications of clinical disease in New England Journal of Medicine about a month back. I don't remember if I put it in the IRA group, where they showed that in mouse models that there was raised CCL 11, I think, in microglia and oligodendrocytes of mice who were injected with COVID-19. And then they got, even after 7 weeks, they had long COVID syndrome. So I think that is one theory that they're coming out with. There is some demyelination in these because of neurotropism to that area. Otherwise, many people were actually doubting whether there is something like long COVID. You know?
Thank you for the presentation. Beautiful. Congratulations. And I think we need some sort of another lecture sometime later as post-vaccine syndrome, because I feel that so many people have suffered more of the vaccine than of the COVID itself. Personally, I'm one of them. Thank you.
I have a question for Dr. Ramanan. Suppose there is a high-risk patient, say a 65-year-old male with diabetes, and on day 7 of COVID illness, he develops fever of 102. No other apparent cause of fever is there. Now, such a patient, will you hospitalize the patient? Even if the patient is not hypoxic, will you advocate steroids to the patient? Especially so if the patient's CRP levels are 76 as cutoff and dimer levels of say around 1000.
Can I ask a question? Just is that okay, or there's no more
Let him
time?
answer the question, please.
Oh, sorry.
Yeah, no, I wouldn't, because we never hospitalize anyone who doesn't need oxygen. And in our trials, we didn't try in the non-hospitalized population. And in a diabetic without needing oxygen, steroids, I think, is prone for more problems. So I don't think we should panic. I'd reiterate, a lot of us have the ability to fight viral infections. by ourselves. It's only a proportion who are going to get moderately ill and a proportion who are going to get severely ill. In fact, if you compare the risk ratio, if you're 75 years old and if you're 17 years old, you have a 15,000 decreased risk if you're age 17 of dying from COVID compared to if you're age 75. So a sense of proportion sometimes, and I think it's not a particularly virulent virus, it's just more at risk in certain populations. And I think the work by Paul Bastard, who showed that the risk groups are the ones who have anti-interferon antibodies. So there is something about the innate immune system in those who succumb to COVID, which hasn't been fully explored yet. Why is it that some 70-year-olds succumb and some 70-year-olds are able to fight it without much problems?
So you would advocate the patient to be observed at home?
That's what we do in the UK. You cannot get a bed unless you have organ failure or hypoxia.
Okay.
Can I?
Last question, please.
Yeah, YK from Singapore. So I have two questions. So one is to Professor Raman. You didn't mention the role of remdesivir and the monoclonal antibody like Evusheld. And in your study, did the patient receive this, and was there any difference? For Shinoy, excellent work. Yeah, I agree with you. The inactivated virus is like water. I always tell that to my patient. All right, but in Singapore, you need 4 doses of the inactivated. We call it Sinovac or the Sinopharm in Singapore. It's from China, and that would be at 0, 8, 20, and 42 weeks. So my question is, what is the schedule of the vaccination in India? But with this dosing, I'm sure you're aware that the rate of death of COVID-19 in Singapore is probably one of the lowest in the world. And what we have observed is that the risk with this scheduling, the risk of serious infection is actually very, very low. So leading to that, I think if you look at the Pfizer mRNA vaccine that was published in NEJM in September this year, the original Pfizer vaccine efficacy against infection in this group of children from 5 to 11, vaccine naive, was only 70% against Omicron. And it drops to 40% in about 3 to 4 months' time. But the protection against serious infection was consistently close to 90%. So I've been offered the bivalent vaccine as a booster. I've had 3, I've been infected, I had hybrid immunity. I'm actually not keen. And do you think that is there a need for the booster? And as I said, you know, the mRNA vaccine is rough, especially with my 3rd dose. So yeah, sorry, this lots of questions. Thank you.
So basically, what you are asking, what I understand is that whether should you boost after the 3rd dose, after you had an infection, 3rd booster should we boost? No, frequent boosters doesn't work. That's what I showed. Because if your antibody titers are very high and you are giving a booster, it actually causes some kind of dip in your immunity. So it is not recommended. For an immunosuppressed patient who has not, for example, somebody is on rituximab, you have given 3 doses of vaccine, it may not have worked. In those kind of patients, we need to give. So there is not a rule of thumb. Basically, we have to individualize, and the best surrogate marker what is available currently is antibody response for the protection against disease, and antibody response most of the time goes hand in hand with T-cell immune response.
And just another point to add, vaccinating.
Dr. Sinha, I have a question. I am from Kolkata, I'm professor of medicine. I have seen that in our hospital, we have given this Covishield. Even after 3 doses, the patients are being suffered, not 1, but twice, thrice with the COVID. Though it is not such symptomatic, but it is, infection is there. So, can you explain please?
Because Covishield, I have shown my slide that Omicron neutralization is very, very weak. So against Omicron, the efficacy is very low, less than 50% probably or less than that. And what works against this is hybrid immunity. Hybrid immunity people do reasonably much better. And there are a lot of things, a lot of work needs to be done. Why certain people do not respond, even in normal population, there is a lot of work needs to be done. What we have done is just 2% of what needs to be done, or less than that.
Thank you.
Thank you. Thank you very much, sir. If there is no more question, we will call it a day. Thanks to the organizer for giving this nice opportunity.
response, sir.